Hi, good morning, everyone, and thank you for joining us today. I'm Samantha, and I work with SLACOS as the Director of Member and Partner Services, and we're excited for the opportunity today to present to you our next installment of our free Webinar Wednesday series, brought to you by Health Service Advisory Group. Today, we'll be discussing the new CMS Quality Payment Program. And before we get started, I'd like to go over just a few quick items so you know how to participate in today's event. You should see an attendance interface on your computer desktop in the upper right-hand corners. You can listen in via your computer speakers, or if you would like to join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing in your questions into the questions pane of the control panel. You may also send in your questions at any time during the presentation, and we will collect these and address them during the question and answering session at the end of today's presentation. With that, I'm going to turn over the presentation now to Rachel and Betty, who are here to present on behalf of Health Service Advisory Group. Thank you both for being here today, and have a great webinar.
Good afternoon. First, I'd like to thank SLACO for extending the invitation for us to present. And thanks to all of you for joining the HSAG Florida Physician Office team. My name is Rachel Ortel, and I'm a Quality Improvement Specialist with the Florida Physician Office team. And I'll be your moderator for this presentation. Today, we plan to provide the latest information on the Quality Payment Program and what the Medicare Shared Savings Program members need to know for 2017. Before we get started, I'd like to introduce you to our Florida Physician Office team. This is our Florida Physician Office team. Many of you have had the luxury of working with our team for many years, and we're happy to support over 500 practices throughout the state of Florida on quality improvement and quality data reporting. And our team has grown, mainly due to the outreach with the Quality Payment Program implementation and also the Merit-Based Payment Incentive Program. Here's what our session for today is going to look like. Our agenda will include a brief HSAG introduction, a QPP overview, and an overview of the eligibility criteria and scoring requirements for the Medicare Shared Savings Program participants in the Quality Payment Program. As we go through the presentation, please feel free to submit questions in the chat section, and then, time permitting, we will answer those questions at the end. Any questions not answered will be provided a response after the webinar. Many of you may be new to your role in our organization or unfamiliar with Health Services Advisory Group, also known as HSAG, what we do, and how we serve the healthcare community. HSAG is the Medicare QIO for Arizona, California, Florida, Ohio, and the U.S. Virgin Islands. Together, these states represent nearly 25% of the nation's Medicare beneficiaries. Our mission is to coach, advise, and support various healthcare settings to improve patient safety, reduce harm, and improve clinical care, to engage healthcare providers, stakeholders, and beneficiaries in improving health quality, efficiency, and value, to drive quality by providing technical assistance through sessions like this, also known as Learning and Action Network events, and to collect and analyze performance data for improvement. Health Services Advisory Group is one of 14 Quality Innovative Network Quality Improvement Organizations, also known as QIO, across the nation, funded by CMS to support hospitals and other inpatient and outpatient facilities, physicians' offices, nursing homes, and home health agencies with free education and technical assistance in improving patient outcomes through quality methodologies and learning and action networks. For more information on HSAG services, you can visit our website at www.hsag.com. Now I'll turn the call over to Betty, one of our health informatics specialists who's been with our team for over 12 years and working with medical practices throughout Florida. Betty?
Thank you, Rachel, and good afternoon, everyone. Thank you again for joining us.
We have quite a bit of information to cover today, so I'll jump right into the presentation by starting with Medicare payments prior to MACRA. So first, starting with Medicare payments prior to MACRA, or the Medicare Access and CHIP Reauthorization Act. The MACRA legislation was passed in April 2015, and the Sustainable Growth Rate, or SGR, methodology prior to MACRA applied to physician payments. Now, this flawed methodology required annual doc fixes to avert cuts up to 21% in Medicare payments to clinicians. MACRA repealed this methodology and set forward flat payment updates to the fee schedule. MACRA also authorized the Quality Payment Program. The Quality Payment Program will reform physician payments for more than 600,000 clinicians across the country, and clinicians will have the ability to choose how they want to participate in the QPP under 2 tracks. Those 2 tracks include the Advanced Alternative Payment Model, or APM, and the Merit-Based Incentive Payment System, also known as MIPS. Who can participate in MIPS? Those clinicians that can participate in MIPS are Medicare Part B clinicians that bill more than $30,000 a year and provide care for more than 100 Medicare patients a year. The type of clinicians includes physicians, which also are your MDs, DOs, chiropractors, podiatrists, dentists, and optometrists, as well as physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. Now, these type of clinicians will be eligible under the MIPS program for the first 2 years, and CMS has the ability to expand those who can participate in future years. There are a number of exclusions under MIPS. The first one deals with those clinicians who become newly enrolled in Medicare. This would be their first instance where the clinician joins Medicare, and if they join during the performance period, they would be excluded from MIPS for the first year. That means that any clinician would not be eligible to receive either a positive or negative payment adjustment in 2019. The second exclusion deals with those clinicians that are below a low volume threshold for Medicare Part B allowed charges. Again, that is less than or equal to $30,000 a year or 100 or fewer Medicare Part B patients. The last exclusion category, which is the primary focus of this presentation today, are for those who significantly participate in advanced APMs at either a qualified participant or partially qualified participant level. Now, the next slide provides a breakdown of the different participation levels for the Medicare Shared Savings Program track. You'll note that Track 1 ACOs, also known as Shared Savings Program, are categorized as MIPS APMs. MIPS APMs are MIPS-eligible clinicians that are members of an ACO. All MIPS-eligible clinicians in Track 1 ACOs are subject to MIPS, but they're subject under the APM scoring standard. Also, these clinicians are considered a group and will receive the same MIPS score. Track 2 and 3 shared savings programs are considered advanced APM, and they are exempt from MIPS. It's important to clarify that while these clinicians are exempt from MIPS, they are still subject to the reporting requirements outlined under their advanced APM model. So the APM scoring standard in general is a way to bridge the gap between APM participants and the MIPS program. So these 2 tracks overlap a little bit, where if you're not in an APM or an advanced APM and excluded from MIPS, you'll still be subject to the MIPS reporting requirements and payment adjustments. But you're also doing activities under the APMs, And so this APM scoring standard is designed to make that a seamless transition and reduce the burden so that CMS takes account of the activities that you're actually doing for the purposes of the APM and translating those over to MIPS so that you don't have to do duplicative or conflictive reporting across two programs. And so MIPS APMs are a type of APM. So again, it's a subset of APM, kind of like advanced APM, but a little broader than advanced APM. So we'll capture more types of APM in that. But generally, they hold people accountable for quality and cost of care. So CMS wants to take account of that and use that for purposes of MIPS. So the general premise of it is that all the eligible clinicians in an APM entity, again, that ACO organization, group practice, hospital, depending on the type of APM we're talking about. So all of those eligible clinicians will be assessed collectively, and they will receive the same MIPS score and the payment adjustment for that particular year. So when we say MIPS APM, we're talking about the specific type of APM, one that essentially meets all three of these options. First, they have an agreement with CMS. Second, there are one or more MIPS eligible clinicians on a participant list so that we can identify the clinicians who are subject to MIPS. And then lastly, the APM bases payment on cost and quality. So that's assuring us that they're being assessed for the things that MIPS assesses, but they're just doing it through the APM instead. So this is how CMS will determine who is part of an APM for purposes of this APM scoring standard under MIPS. They'll start by looking at 3 snapshot dates, and by the end of it, they'll have the total group, or the list of clinicians who will be a part of the group of the APM entity. And they'll all receive the same MIPS score and payment adjustment. So CMS will do that by looking at these 3 points in time. And if you're in the list at any one of these points, you'll be considered part of that group. So on March 31st, CMS will look at your participation list, and everybody in that list for a particular group is considered part of that group. And that can't be taken away from them. And then on June 30th, they will do that again. So any additional people would also be included in that group. But everyone on the March 31st is still included there also. And then CMS will do that one last time on August 31st. And any people who have subsequently joined after the 2 previous snapshot dates would then be considered in the group. So it's really additive over time. And by August 31st, you'll have your full group. Everybody there then be considered one unit for the purposes of the APM scoring standard. So then these are the APMs that CMS considers MIPS APM. And so these are the ones where you get a special APM scoring standard by participating in these. And you'll see the CEC model, the CPC Plus model, the Shared Savings Program tracks, the Next Generation ACO model, and the oncology model, oncology care model. The difference here that you'll notice if you saw the advanced APM group is that there's a lot of overlap. So there are APMs that can be both advanced APM and MIPS APM. However, for the advanced APM, most of those participants will meet those QP thresholds and they'll be excluded from MIPS. However, if they don't meet those thresholds,
they'll fall back into this APM scoring standard, so there won't be a lot of additional work for them to do, and it will be ready for them to participate in MIPS. And then for these other tracks, they may not have a two-sided financial risk, meaning that they don't have those elements of financial risk such that they're responsible for repaying or reducing their payment rates or having payments withheld. But they still account for cost so that there can be shared savings elements. So they're being assessed for their cost of care. So that's why you'll see things like the Shared Savings Program Track 1 or the one-sided arrangements in the CEC model or the OCM model. So this is the complete list of the advanced APMs. It's available on the CMS website at qpp.cms.gov. I recommend that you go there to see the comprehensive list of APMs and which ones will be scored under the APM scoring standard and which ones are advanced APMs as well. So here we start with the definition of an alternative payment model, and this is a very broad definition, and this was set by FCRA statute. So when we say the word APM, it means this huge universe of payment models that we use, and they're all tied together by the fact that they're new approaches to paying for care under Medicare, and they can change the way that we reward quality and value. And the CMS Innovation Center produces a bunch of these new models, these new payment models every year. So when we say APM, it means any of these four categories. So that's CMS Innovation Center models other than the Healthcare Innovation Awards, the Shared Savings Program, any of those tracks under the Shared Savings Program, or those last two, or any other federal demonstration required by law. So collectively, this is the world of APM. So when we say APM, that's the starting place. And then from there, we'll narrow things down for certain types of APM. So this is the definition of an advanced alternative payment model. These are where the incentives are in the quality payment program. So you start with the APM definition, and then you have these subsets of those APMs or advanced APMs. And they tend to have greater rewards, both in the design of those types of APMs themselves, their greater risk, greater reward types of payment arrangements. But then what the quality payment program does is add an additional bonus on top of all those APM-specific rewards that you have in order for taking on that additional risk, for being in an advanced APM. And there at the bottom of the slide, it's important to note that what the quality payment program does is add these extra incentives, the 5% lump sum incentive. It does not change the actual terms of the advanced APM itself. So all of those terms and conditions that are inherent to the APM, those remain the same. The quality payment program does not change any of those elements for how the new payment arrangement change the way that Medicare pays for care. Rather, it rewards just adoption of that new payment arrangement. And so this is a more explicit layout of the rewards on the advanced APM track of the quality payment program. So for participating in an advanced APM, we will identify those participating clinicians as qualifying APM participants, or sometimes you'll see QP. And so these QPs receive these specific rewards for being in advanced APMs, in addition, as we said earlier, to what the APM itself offers. So first, qualifying APM participants are excluded from MIPS, so they won't have to do any additional reporting requirements or receive any of those payment adjustments associated with MIPS. Instead, they'll receive a 5% lump sum bonus, and that lump sum bonus is based on their Part B professional service payments. And that is limited in time. So the first lump sum payment will go out in 2019, and the last one will go out in 2024. So after that, the long-term incentive for being in an advanced APM is in the fee schedule. So these QPs will receive a higher fee schedule update starting in 2026. And so from there, that compounds upon itself so that QPs will get a higher and higher fee schedule rate relative to non-QPs over time. So those two lines will diverge from one another. So every year that someone participates in an advanced APM, they'll have an opportunity to receive this higher fee schedule update. And so this is a summary of the incentives that we talked about. So side by side, starting from the left, if you're not in an APM and you meet the criteria to be part of MIPS, then you'll receive those MIPS adjustments, but you won't receive anything in addition to that. If you are in an APM that is not an advanced APM, you're still subject to MIPS reporting requirements and payment adjustments, but you also get whatever is inherent to those APMs. So as we said earlier, those APMs have their own risk and reward structure. So those do not change under the quality payment program. And as we'll talk a little bit later, there are specific ways that we score APM participants under MIPS. So there's some certain favorable scoring elements under MIPS as well. On the far right side, in an advanced APM, you have the opportunity to be excluded from MIPS. So no reporting requirement, no MIPS payment adjustments, but you get those APM-specific rewards. And for advanced APM, those tend to be a little bit larger than those for non-advanced APMs. And then finally, those advanced APM participants receive that 5% lump sum bonus. So that's an automatic payment that they'll receive. So here we'll talk about what makes an APM an advanced APM. So as we spoke about earlier, there's this broad definition of what APMs are. Those are innovation center models, that shared savings program, and any other federal demonstrations. From there, starting with those payment arrangements, we ask in their terms and conditions, the requirements of those payment arrangements. Do they meet these three requirements to be an advanced APM? We look at those legal instruments that govern how those payment arrangements work and ask, do we check these three boxes here? So first, does the APM require participants to use certified EHR technology? Second, does the APM provide payment for covered professional services based on quality measures that are comparable to those used in the MIPS quality performance category? And then third one is an either or. So there are two ways to check this box. So either that APM is a specific type of APM that we call a medical home model, and it's been expanded under CMS Innovation Center Authority, or the APM requires its participants to bear more than nominal amount financial risk. So you check all three of these boxes, and an APM is an advanced APM. So that's what we'll go into detail in these next few slides about what each of these means in greater detail. So the first criteria for an APM to be an advanced APM is about using certified EHR technology. And when we say certified EHR technology, we mean the same technology that is used in the Advancing Care Information Performance category under MIPS. So that we're not talking about two different definitions for certified EHR technology. So when we look at it at an APM, the APM must have a requirement of its participants that at least 50% of the clinicians in each APM entity use certified EHR technology to document and communicate clinical care. What that means is that an APM entity is that participating entity or organization that signs an agreement or is subject to a payment arrangement with CMS. That can be an accountable care organization, a hospital, a group practice, depending on the type of APM, determines which an APM means. So you look at that APM entity, and we look at all of the clinicians in that entity, and the APM must require that at least 50% of those clinicians use that EHR technology in this prescribed way. For the Shared Savings Program, it's slightly different, and so the Shared Savings Program will actually require its participating TINs in each accountable care organization to report the Advancing Care Information category under MIPS. And by doing that, they'll meet this criteria. So that the new requirement that those ACOs report to the Advancing Care Information Performance category under MIPS checks this box for the advanced APM criteria. So this second criteria is about quality measures, and the APM must base payments on quality measures. And those quality measures must be considered comparable to those in the MIPS quality performance category. And this is a fairly flexible criteria. So what we determine comparable means is that the APM uses quality measures that are evidence-based, reliable, and valid, and those come from a variety of sources. So they can be actual MIPS measures, they could be consensus-based, entity-endorsed measures, they could have been tested in another APM and proved to be evidence-based, reliable, and valid. So as they are evidence-based, reliable, and valid, they are comparable to MIPS measures. And then that second bullet there is about outcome measures. So the APM must also tie payment to an outcome measure. There's a slight exception to that. If the APM focuses on a specific specialty or clinical condition for which there is not an outcome measure available in the MIPS measures list, then that requirement for an outcome measure does not need to be there for the APM to be an advanced APM. So this third criterion, and it's all about financial risk. And this one's a little bit tricky, so we have a couple of slides based on this. So first of all, we'll look at that second part, which is the one where we'll look at most APMs through this second part of either or, and that's, does the APM require its participants to bear more than nominal amount of financial risk? And I'll note that when we say participants, we really mean that APM entity. So it's the entity that has the agreement with CMS that must bear the risk. CMS does not prescribe how those downstream risks arrangement must be made with individual clinicians or organizations within the APM entity. So we're going to split this into two parts. So first, on the left, you see that there's financial risk, and on the right, there is how much risk. So first, on the left, this is what bearing financial risk means under an APM. And that's the APM may withhold payments for services. They may reduce payment rates or require direct payments. So any of those structures within the design of the APM itself could be considered requiring its participants to bear financial risk. And then, if that's present, then we look on the right side to see how much risk are those entities required to bear. And we focus only on the amount of risk, and that's the maximum amount that any APM entity could lose under the terms of the APM. And CMS will do that in terms of two different things. So there are two ways that an APM could meet this amount of risk criteria. And the first is looking in relation to Medicare revenue of its participants, and also the total amount of risk that participants must potentially lose is it must be at least 8% of the average estimated total Medicare Parts A and B revenues of its participating APM entities. So for those participating entities, they must add up their Part A and B revenues and ask, does this APM put at least 8% of this at risk? If so, that APM would meet this criteria. The second way we look at this is in relation to the benchmark, or the expected expenditures for which an APM entity is responsible under the APM. So that can be considered something like total cost of care for beneficiaries for whom an accountable care organization is responsible for. And this relates a little more closely to how our current APMs usually operate, which is on that total cost of care element. And this just says that the APM entities must be responsible for at least 3% of that benchmark amount of those expected expenditures. And if so, that amount that they could lose is at least 3%, then it meets this criteria. So at the end of all of this, CMS won't require everybody to do these determinations on their own or understand all the math within the APMs and the lines those up against those criteria. CMS will make these determinations and make them present on the qpp.cms.gov website so that a clinician can go to that site and see the comprehensive list of APMs and understand which of those have met which of the previous criteria that we discussed, and then we will identify each year which APMs are advanced APMs. So we've identified what advanced APMs are, and we have those participants in advanced APMs, but then we need to identify the actual clinicians who will receive the rewards under the quality payment program. And so those are the qualifying APM participants. So when we say qualifying APM participants, or QP, we're talking about the specific clinicians who are participating in advanced APM, and there's a specific threshold that the macro law set forth to identify which clinicians are actually participating in advanced APMs. And they, either individually or as a group, collectively have enough of their Part B payments or Part B patients through that advanced APM. And that's saying that they're sufficiently participating in advanced APM to receive these rewards under the quality payment program. You'll see that beginning in 2021 of payment year, so performance on the right side of the slide, you'll see that beginning in 2021 of payment year, so that's the performance period of 2019, that threshold for percent of payments or patients through an advanced APM may be reached through a combination of both Medicare and other non-Medicare payment arrangements. So we won't just focus on Part B, but we could also focus on payment arrangements with private payers and Medicaid. This will start in the third year of the program. So we won't go into great detail with that here, but there will be more information about those potential arrangements and ways to become a qualifying APM participant in the future. So we'll go through a series of steps here to go from how we identify those participants to them actually being identified as qualifying APM participants, meeting those thresholds and receiving rewards. So the first step is that CMS will make these qualifying APM participant determinations at a group level as a default. So everyone participating in an accountable care organization or a group practice or are gain sharers with certain entities, those will all be collectively assessed as one unit. So they will become qualifying APM participants or not become qualifying APM participants altogether. Now, CMS has one exception to that, where for certain types of APM, there's not a participation list of a single cohesive group of participants working together, but rather they have affiliated practitioners who may collaborate in a variety of ways with that APM entity, but they're not necessarily part of the same unit, working collectively together. So in those particular cases, CMS will identify these QPs individually and do the calculations one for each person as opposed to doing it as a group. So then the next step is to identify a percentage threshold score for that group, and then we'll do that using two different methods, and we'll do that in parallel. So we'll do two methods at the same time, and they're both based on Part B professional services. Just one is focused on payments for those services, and the other is focused on the actual number of people served through Part B professional services. And both of these methods are also parallel in their concept. In that, we consider what is through an advanced APM as based on their attribution. And attribution is who the APM entity in those clinicians are responsible for under the terms of the advanced APM. So for the cost and quality of care that you provide specific beneficiaries, that's what you're assessed on under advanced APM. So that is what's going to go in the numerator in this percentage calculation. In the denominator in this concept called attribution eligible, that's really a set of beneficiaries who could potentially have been attributed to you. They may have been attributed or they may not have been, but that is representative of your overall Part B population that you serve. It narrowed just a little bit for those who cannot have categorically been attributed to you. So then the second part of this second step in doing that actual calculation, as I said earlier, we'll do both of these methods in parallel, so you won't end up with two threshold score percentages, one using the payment amount method and one using the patient count method. They're parallel, again, using attributed over attribution eligible. It's just the payment amount uses dollars for the Part B professional services. So what you've been paid for those services and the patient count is just coming up with the number of beneficiaries who fit into those categories. And then once we have those percentages, threshold scores, we compare them to this table. And this is a table of QP thresholds. And so you'll notice that there is one set of thresholds for that payment amount method and one set of thresholds for the patient count method.
And there are very little, the patient count method, and they vary a little bit because those ratios tend to work out slightly differently in practice. And so CMS will take that payment amount threshold percentage and compare it to these numbers here, and then they'll take the patient count threshold and compare them to that second row. And you'll notice that both of them increase incrementally over time. So starting in the third year, and then again in the fifth year, they bump up a notch to be a little bit higher and more challenging to reach. So it requires greater commitment and greater, broader service through that advanced APM in order to meet the thresholds. Now, then finally, in wrapping back to what we said originally, if that group collectively meets those thresholds, so their threshold scores is greater than the thresholds in the table, then everybody in that group will become a qualifying APM participant. If they don't meet that threshold, then the group will not become a set of qualifying APM participants. Now we'll get into laying out how we actually look at things over time. What periods of time we use to do these assessments and how we actually calculate the amount of that 5% lump sum payment reward. So first, on the left-hand side of this graphic, you'll see that there's a QP performance period. That's where CMS will look at our clinicians participating in an advanced APM, and if so, do they meet the threshold as a group? If so, they'll be identified as a qualifying APM participant using that QP performance period data. Then we take those QPs, and in the subsequent years, which we call the incentive payment base period, that's where we determine how much they're going to get as a reward. So we look at all of your Part B professional services during that year, and we take 5% of the payments for that, and we make that payment to them in the payment year as a lump sum payment, so that the progression, so that's the progression, is QP performance period. Incentive payment base period is how much you get paid. And we actually make that payment in the payment year, and so that will also overlap. So again, looking at the three snapshot periods in determining eligibility for a QP in an advanced APM, we see again that March 31st date, the June 30th, and the August 31st. So by the end of the August 31st, everybody who is on the list in March 31st will still be considered part of the group, and anyone collectively that's been added through the years. So that's the end of the QP performance period. And everyone who is not on the previous snapshot would be included in the group. So that gets a little bit more technical. And I won't go over this slide. I really want to, for the lack of time, I want to allow you all to ask questions. So I really wanted to kind of summarize this presentation by basically stating that a lot of this calculation, if you are a member of an APM, a provider, a lot of these calculations will be done in the background. There's nothing that you need to do. It would be your APM entity that would let you know whether or not you are part of an APM. But from a clinician standpoint, I'm a member, I am a provider within an APM. What does that mean for me? How do I put all of this together? So as the QIO, this is where we can help you provide technical assistance to you in this area. Because we do understand that for most APMs, your APM entity is responsible for reporting on quality, and you automatically receive full credit for the improvement activities. The only category that you may need to report on your own would be the advancing care information category. And that's where we can help you make sure that you are understanding the reporting requirements and provide customized technical assistance to make sure that you're meeting the advancing care information. So we put together a little checklist, and this is specifically at the clinician level. These are things that you will want to do within your practice to make sure that you are well prepared to help your APM entity have a good score and earn that potential bonus. So going down the list of things that we have, determine your eligibility and understand the requirements. Now, as I said, your eligibility, that is something that will already be determined for you. It's your responsibility to follow up with your APM entity, whoever is the head of your APM, so that they clarify whether or not you're eligible. The second criteria is to choose whether you want to submit your data as an individual or part of a group. Understanding that the quality and the improvement activities, that is automatically, as an APM entity, you'll automatically report as a group for those two categories. However, you can elect to report, which is something that's new this year, you can elect to report on the advancing care information category as a group. And that could be very beneficial to some practices. The next thing that you want to do is choose your submission method and verify its capabilities. That's where you want to make sure that you are reaching out to your EHR vendors. There's a lot of vendors that need to update their systems to meet the reporting requirements for 2017. So being in constant contact, being aware of when they're pushing out these updates and the capabilities of what they'll be able to report on is really beneficial for you. The next thing you want to do is prepare to participate by doing a practice readiness assessment. And that means, you want to have a capability to run your reports out of the EHR to see how you're performing. The last thing that you want, the last couple of things that you want to do is verify the information that you need to report successfully. Next, you want to care for your patients and make sure that you're recording that information correctly within your EHR. And then lastly, you want to make sure that you're submitting your data whether it's to CMS directly or to your APM or ACO entity, that you're submitting your data to them by the deadline. So that's about all that we have. I'm going to turn it back over to Rachel to close out the session, and we will then open the line up for questions. Thank you.
Thanks, Betty. Now that you all have a better understanding of how Medicare Shared Savings Program participants participate in the QPP, we'd like to share a little bit of information on how you can receive no-cost technical assistance and support. Like Betty said, we understand the unique reporting requirements of ACO participants, specifically in that the majority of your reporting will be done through the ACO. Some clinicians might still need assistance with the Advancing Care Information category, though formerly known as the EHR Incentive Program or Meaningful Use. And so that said, there's several ways that you can contact us for support. You can call HSAG toll-free at 844-472-4227, like it shows on the slide. And we're available Monday through Friday from 8 a.m. to 8 p.m. Eastern Time. Or you can even email your request for QPP assistance to our HSAG QPP support at hsag.com, and a QPP specialist should be able to contact you shortly thereafter. And just as a reminder, the deadline for submitting the Advancing Care Information hardship application is October 1st. So if you have any questions on your eligibility for that, we do have our QPP specialists online so that they can provide that kind of guidance. And one final recommendation, please be sure to subscribe to the QPP listserv so that you can stay informed with any new resources to guide you in your MIPS data submission. And you can register for the Medicare Learning Network. Continuing education credit might also be available for you with some of the Medicare Learning Network courses. So thanks again for the opportunity to present, and of course we really look forward to working with you. And this concludes our presentation part of the session today. We may have just a few minutes left for some questions, so let's see if we have some questions in the chat. Samantha, are you there? Do we have any questions in the chat?
Yes, ma'am. We have 3 questions today, and so 2 of them are from Betty Cook. And her first question was, and Betty, I did take you off of mute, so you'll be able to talk as well. She asked, do the ACO practices need to continue submitting CPT-2 codes on the claim forms for the preventative measures performed in 2017?
Okay, my response to that question is it really, I would recommend that she continues to report the CPT-2 codes, because the ACO entities are actually, that's how they satisfy some of the measures that they're reporting on. If you look at the specific measures, there are some that are reportable by claims, and the APM or the ACO entity collects that data through claims. So that's the easiest way for the ACO to get the data from you without doing manual chart reviews. If you've already reported it, then they don't have to come back to you to say, you know, we need this information on a patient. So if there's any way that you can report on a quality measure by claims, that's beneficial to the APM's reporting.
Okay, thank you. She did have one more question. Does each physician in a Track 1 MSSP need to report AIC, the Advanced Care Information, through their EHR in 2017 without regards to their meaningful use status?
Actually, for this year, Track 1 ACO participants will need to report the Advancing Care Information category. Now, there is certain instances where providers may still claim the exclusions or the hardship exemptions. So even if you're not able to participate in the advancing care information, you still want to at least file the hardship exemption or request to CMS to have that category reweighted to a different category. So one of the criteria for the ACO, you know, part of their scoring is that for the use of EHR is that 50% of their members are CERT users. And CMS is identifying that 50% by the number of clinicians that actually attest to the advancing care information category.
Thank you for that. And we do have one more question from Tracy. She asked, are you hearing anything about some of the ACOs not being able to report for their physician members?
I have not heard anything regarding that. I could speculate on some reasons as to why the clinician may, they're being told that the clinicians may have to report on their own, and it has to do with those snapshot dates as to when the provider is included on the participation list for the ACO. Also, there's quite a number of ACOs that are disbanding, so that could be another potential reason why they're saying that they can't report for their clinicians. If you have, we'll be more than happy to investigate for you, so if you want to reach out to us directly, our 800 number is there. Some of you may have our direct phone lines because we've worked with you in the past. So if you have any specific questions like that, just feel free to reach out to us. And if we don't know the answers, we will definitely be relentless in getting you an answer from CMS.
Okay, and one more question that did just pop up. Is there a deadline to complete the A1C? Is there a beginning date for a submission period, or is the recording period completely controlled by the EHR vendor?
Well, if you're reporting the measure by EHR, then the specification should be built within those within your EHR. Now, you really need to, for clarification, you really need to, if you have any questions about the frequency or when you should report, you want to review the specifications for the measures on the QPP website, the qpp.cms.gov website. Under the resource library, there's a measure specifications file that contains all 271 measures that are available for 2017. I would highly recommend that you download the individual specifications for the measures to look over the requirements. And again, that is something that we here at the Support Center can definitely help you walk through.
Okay. Is there, oh, wait, I do believe we have one more. Oh, nope, we're good. All right. Both Tracy and Becky appreciate your answers, as I'm sure everyone else on the call does today. And since we have no more questions, this will actually conclude our webinar for today. I just want to thank Rachel and Betty both for taking their time out to present this information today. I know it's a hot topic, and I know everyone was really interested. So thank you again. Once you do exit, you will receive a survey on the presentation within about a day, and we would definitely appreciate your feedback, as it'll only allow us to grow and give more great webinars to you guys. Also, just want to give everybody a quick reminder that we hope to see everyone in October 19th and 20th at the FLACOS conference. And if you want some more information on that, just go ahead and check out our website, flacos.com. Again, thanks again to the Health Services Advisory Group, and we hope you have a great day.
Thank you.
Thank you.